All right, thanks everyone for joining us today. My name is Lisa Towers. I'm Director of Marketing for Lumina Health Partners. Today we are presenting our webinar in conjunction with Hogan Marren Babbo Rose, and our topic today is governance structures, academics, and critical access. We hope to see you on our next monthly webinar, which is titled A Proven Blueprint to Pathways to Success on August 14th at 11:30 a.m. Central. Today our presenters are Dan Marino, who's Managing Partner for Lumina Health Partners, and John Marren, Founding Partner and Shareholder for Hogan Marren Babbo Rose. So welcome to both of you, and I'll turn it over to Dan.
Welcome everybody. Appreciate you taking the time to go through the webinar today. Interesting topic that we have to discuss. A lot of work being done across the country with provider organizations really starting to take a lot of their specialty services and expand them into clinical service lines. And what we're starting to really to see are leading healthcare organizations really positioning themselves differently. You know, again, trying to create this alignment around the specialties that include not only the employed providers, but a lot of the independent providers. And they're doing this in a way to create some real strong geographic focus. But the key to that is to create, is what we're starting to see are these organizations are really creating themselves or positioning themselves as a differentiator in the market. They're doing this in a way that they're able to present some advanced care models, really focusing on a lot of the quality initiatives, utilization tracking across that whole continuum. And probably the most important is they're really focusing on how they can start to bend the cost curve, focusing a lot on those patient outcomes and the patient experience, but doing it in a way that creates a lot of efficiency, doing it in a way that really allows them to achieve the highest level of outcomes, especially for those complex specialty services. Hospitals have the ability to engage directly with physician leaders. And one of the things that we're finding that is exciting to physician leaders is it's giving them the ability to really own this clinical service line and really to begin to expand that beyond just the four walls of the hospital, but really thinking about that across the whole community. And what it's doing is if, you know, as organizations are really starting to formulate their clinical service line strategy, is it's creating new revenue streams, it's creating new incentives, particularly for independent specialty providers, and it's creating new relationships with not only the independents, but then other ancillary services, as well as then the payers that we're starting to really see emerge. The other thing that's happening are these really are occurring around relationships and around structures that are different than merging the assets. And John, I know you've been doing a lot of work in this area. Very pleased to have John Marren here today, who's really a leading expert on the legal components of clinical integration as well as the clinical service lines. John, maybe you could talk for a few minutes. You know, what have you seen in terms of how these have been structured to help take advantage of some of the performance outcomes as well as mitigate some of the legal aspects?
What we're seeing is a variety of reasons why hospitals are doing it. Quaternary hospitals are doing it because they want to work, any hospital that wants to work closely with other hospitals in its area, preparing for population health. Quaternary folks who want to assure referral lines and processes. Hospitals in contiguous service areas who want to come together and offer a product to payers, which is, as you mentioned, Dan, is important. This is really, a lot of people understand clinical integration of physicians allowing you to collectively negotiate on their behalf. This is the same legal application that you can then begin to go in a bundled way or in a collaborative way and negotiate with payers. And we haven't seen any test cases, but we have talked to the FTC about this model for a while. And if it meets the test of clinical integration, if you're actually focused on quality metrics, improving performance, lowering costs, you fall into the rules for lawful collective negotiation.
Yeah, you're absolutely right. And I think the interesting thing here is it's really taken the conversations with the payers to a different level. And where the value is really starting to come out is when you take a look at these service lines. And here's an example. It's a cardiac service line. It's bringing together many aspects of the care that are critical on really delivering the highest level of outcomes to patients. So obviously what's included in the hospital is important, and the different services that are important, and connecting with ambulatory is really key. But then being able to really take that to the post-acute setting, tying in physicians both in terms of what I would call that tier one, right? The independent providers, but even beyond that. So you're really positioning yourself as a destination center. And it's really solving two things in my mind. One, it's creating the service line as that high performing clinical aspect of care that's really dealing with a lot of the complex patients. But number two, it's giving an avenue to some of the specialists so they are able to really support the needs of the patient, particularly in a complex care setting. So we're really starting to see these service lines emerge, and as John said, it's really taking it to the new level, as well as then incorporating a lot of the aspects of clinical integration. What we're seeing in terms of the most common service lines, there's really 5 of them that have been emerging. Obviously, cardiovascular services is really a key one. That's been, and we've seen pretty important to a lot of the new contracts and the type of pricing models that have been out there. Neurosciences, also a really important one. We're starting to see in neurosciences even adult versus children or pediatric neurosciences, which is really creating a lot of value in certain markets, particularly for the children's hospitals. Those pediatric neuroscience programs have really been quite valuable. Women's health, again, strategically for organizations, this has been a tremendous focus, and what we're really seeing is for a lot of, bringing together the community hospitals as well as the academic hospitals, creating multi-tiered approaches to delivering high-quality women's health services. The value around that is it's really been able to connect the family to the service line and really to the institution, which has been a fantastic outcome for some of these high-performing women's health service lines. Cancer service line that includes oncology, clearly has been an important one. And, even piggybacking on that, the government has been, about 1.5 years, 2 years ago, released the oncology care model, which has been a great way to begin to test the different pricing activity, as well as then redefining how care is being delivered within the cancer service line model. And the interesting thing about that, and John, I don't know if you can lend any comment to this, but it's created a pricing model that begins to test the performance of the activities around these patients all the way through the care continuum. That to me has really been fascinating.
You nailed it, Dan. The work we've done, it really focuses on best site of care, follow through, seamless data transfer, so that if I'm a big quaternary hospital and I really want to focus on those service lines and those activities and those patients that need my level of care. And if I create a relationship that we're talking about with a rural hospital or somebody who doesn't have that level of services, I can help improve care there by looking at best practices and engaging the physicians in that process, and then making sure the patient gets transferred to me for what they need, and then transferred back so that they're back in, as Dan said, in the community with their family. So it's not a patient getting referred and then you never see them again. It's getting the patient back, getting the local care control that you're talking about.
Yeah, absolutely. Orthopedics is the other one that we've seen a lot of activity around. And some of this has occurred because of, the bundled pricing models that have been out there. But I'll tell you, for certain organizations, they've really put a lot of strategic focus on building orthopedics as a very strong clinical service line and a destination center. And the one that comes to mind is, what Cleveland Clinic has done. They built a pretty strong orthopedic clinical service line, and, they contracted directly with Walmart. That really provided for a lot of direct activity across the country, sending patients to Cleveland to have their services done. And again, they put together a whole protocol. But your point is well taken. Even though patients have been flown to Cleveland to be able to have their service, they're still going back to wherever they're getting their originating care from. And through that connection of connecting the providers, boy, it's been just a tremendous amount of value there.
Right.
So when you look at the clinical service lines, there's four key aspects. We call it the 4 pillars of high-performing care. And these are really the elements that I think are unbelievably important as you really start to think about how you're delivering value around the clinical service line. And it starts with governance and leadership. You have to be able to have an entity that allows the providers to create the right level of incentives, to be able to manage the care across that whole continuum, and really allow you to contract differently between the entity, which in this case would be the clinical service line, and either an employer group or a payer or whatever the case may be. And John mentioned that, and a little later he'll talk about some different structures there. But that entity is really critically important to that success. The other area that we're seeing too emerging as both an opportunity and a need is the development around physician leadership. Because the clinical service line is very clinically focused in terms of the care that's being delivered across that continuum, physician leadership, being able to really both strategically and operationally direct all aspects of the service line is really an area that's unbelievably important. And what we're seeing here as an opportunity is there are senior leaders, physician leaders within the clinical service line who are pretty astute in understanding what they need to do and how that needs to transcend across the institutions and across the different entities. But when you drop down one layer lower, you may have medical directors of the different areas there. That's where we're starting to see a development need of physician leadership. We see as an opportunity here, there's really not enough strong physician leaders in this area. They're starting to emerge, but those that have started to invest in the leadership of their physician leaders within that clinical service line, we see are really positioned quite well for success. The second area,
Dan,
go ahead, John.
Wanted to point out how important what you said absolutely is in where these models have worked. And I'm thinking now of when we were involved with 2 hospitals in their cardiology group. They really did get all the physicians together. As Dan said, create leadership, have the physicians oversee and help develop the protocols for care, the metrics, everything about it. And they now have a joint committee that oversees the whole cardiology service line. So I just wanted to support what you were saying.
Yeah, you're absolutely right. And that leads right into the second pillar. These advanced care models, the new models of delivering care that have to emerge in the clinical service line is really important. And in a lot of cases, they've incorporated team-based care, new models, redesigning the way that patients flow through the different aspects of care, all with the idea that you need to bend the cost curve, you need to manage the care of these complex patients differently, but you're doing this throughout the whole continuum of care that's being offered through the clinical service line, as opposed to having it very siloed as it often exists today. But it does provide some tremendous opportunity for different types of payment models. And, at the end of the day, I'm a huge proponent of form follows function. And you have to understand what the value is, the financial value. If you create the right financial value, then the rest of it sort of takes care of itself. It flows down in terms of ensuring that the alignment of the providers, the alignment of the institutions, even the alignment of the patients are there. And, John, I don't know if you have any comments on the different payment models, but boy, critically important on really making sure that everything is aligned appropriately.
Well, you've got it. We're of the same mind. Why would you go through all this and not get the right kind of incentives? And as MedPAC advised Congress in 2005 in the March 5th report to Congress at Chapter 4, if you want physicians to do something different or better, provide financial incentives, give them data on performance, good data on performance, and don't wait for down the road type incentives. Put the incentives, build the incentives in up front. Yeah. The other point that you alluded to is a lot of the big box people and the other people going directly either to Mayo or Cleveland Clinic or something like that. If you've got something like that in your community, I'm starting to see other health systems come together and integrate like this in order to offer an alternative to the patient leaving the community at all. So It's a competitive strategy.
Yeah, that's a great point. That's a great point. And, a lot of it then leading into the fourth area there is really around the analytics and the innovation. Critical service lines have the opportunity to track patients differently, to track the outcomes and the data differently, and really to parlay that or leverage that into really strong value as you start to negotiate. Plus, it allows you an opportunity then to incorporate different aspects of technology, which you may not be able to really do without having a strong, broad-based clinical service line. So oftentimes, we get asked, well, where do you start? Especially when you're looking at some of the quality outcomes. How do you know if this is going to be of value, especially if you're starting to incorporate some investment dollars and tracking this as a return on your investment? Well, these 7 elements, I think, are some of the key things that high-performing clinical service lines really start to focus on. Everything from patient care delivery to tracking the specific quality outcomes of the specialty, obviously reducing costs, and cost reduction occurs in a number of different areas. It could be direct costs, but in most cases, it's a reduction of what we would consider the medical spend, right? And a lot of that occurs from putting in more efficiencies, ensuring that the patient is utilizing the domestic network. So you could see here reducing the leakage, and then as well as then opportunities to provide some additional revenue capture. And a lot of times it's not all about, cost management or cost reduction, but how do we create new revenue streams? How do we maximize our revenue potential just from the patients that we have here? And if you do this well, you can increase your fee-for-service revenue while you're putting in place value-based care initiatives, while you're creating stronger outcomes, for your patient population. Where organizations have begun to evolve is really starting to think from a clinical standpoint as to how the pathway of success really needs to evolve and integrate well with the clinical service line strategy. Data is key on being able to understand where to start from a contracting standpoint with the patients or the populations that we want to begin to manage. And what we've found with this is if it's done well, you're starting to see the satisfaction level of both patients and particularly providers greatly enhanced. And that provides a lot of opportunity to really, for some further negotiation and really being able to track that further with different levels of conversations, with the payers. So one of the questions that I often get asked by clinical service line leaders is, where do we start? Right? What's included in this? And if we were to launch, tomorrow on our clinical service line strategy, what are the couple of things that we really want to focus on? Well, one, it really starts with identifying the physician leader and delegating to that person the ability to deliver care differently. That care model redesign based on a team-based approach, based on appropriately using the resources, in some type of a leverage model becomes important. And, the way that I think about this is you really have to focus yourself on outcomes and costs, but create a differentiator for you within the market. If you can start to identify yourself as that elements as a differentiator, that puts you on a whole new level as you start to have different conversations with payers, with employers, even with physicians for that matter. The second area is around analytics. It's all about the data, and it's going to continue to be about the data. And it's not that we don't have the data, because we do. A lot of times we don't have the information. So understanding where to start on aggregating the right level of data, for instance, the claims data to understand the medical spend, understand where patients are going, incorporating the clinical data there to answer the question of not only what's going on, but why is it occurring, allows providers the insight to really make change happen. And that becomes really key, especially when you're thinking about maximizing your care delivery outcomes. And then the third is really around cost. And it's not just around cost containment or cost reduction, but it's around efficiency management. And if it's done the right way, what we're seeing from high-performing organizations is that they're incorporating efficiency around value-based care strategies within their clinical service line that really is translating into bending of the cost curve. And by doing that and engaging physicians as to, within that whole process improvement and process efficiency discussions, that's where we're really starting to see a lot of the outcomes. So again, a couple key things within service line reporting. One is to really begin to track where patients are going, track it by volume, track it by revenue, and being able to pull this together to reduce some of the redundancy of care and create some efficiencies leads the clinical service line, to being able to reduce costs, to really being able to identify where some of their outcomes come in, and from a financial standpoint, start to identify what the margin improvement opportunities could be as you start to create some greater, say, payer contracting or bring in additional providers. And let's not forget that patient satisfaction, and in particular provider satisfaction, are really key to this as well. And we have seen this as what I would call more of an intrinsic benefit of strong clinical service line models. So John, I'm going to turn this over to you for a minute and give you an idea, or let you kind of speak to some of the different structures and some of the things that you're seeing there, and then we can kind of talk through some of those high-performing outcomes.
So what you have is basically a lot of differentiation, but in terms of how you could do this, but two general categories. But all the things that preceded this, the idea that you're bringing people together in a team, they're looking at the metrics, they're looking at the analytics, they're coming up with some standards, they're looking at financial measures and cost measures, are all, this just helps facilitate all of that. So you have a couple different systems that come together, and they want to create an organization to actually operate service line integration. And sometimes they'll use their clinically integrated network as part of it, as the entity itself, or sometimes they'll just have, if they have a clinically integrated network, that off to the side, and those doctors participating in the program. If they don't have a clinically integrated network, as Dan said, you still got to develop a cadre of physicians who are really focused on this topic and knowledgeable about the topic, and begin to integrate them into the process. And as he also said, it's a really exciting process, because doctors begin to see themselves as leaders in defining quality. A lot of things that have happened since the birth of managed care tries to convince me as a physician that I'm not in charge anymore. And particularly when we're talking about patients who move from one organization to the next, I don't have that sense of collegiality with my patients. So one of the things you can do is create a joint venture, and within that, you don't have to have these committees, but these are the topics you're going to be talking about. You're obviously looking at quality initiatives. You're obviously looking at infrastructure. You're looking at performance, and some of these can be collapsed. And you should also be looking at payer relations, because this is something that you can, again, if you look back at a couple of slides back that Dan put up, and you talk about all the things that are involved in doing this, that clearly meets the definition of clinical integration for the FTC and DOJ. So you don't have an antitrust issue going to the going out there. And Dan, did you want to add any more about what could go into here, or what other kinds of things? Yeah,
I think the infrastructure piece is really, I think that's probably as important as the structure you're putting in place. As we talk with organizations, you can negotiate the best contract in the world, but if you can't optimize the contract, if you can't, put in place and really be effective within the contract really isn't going to mean a whole lot. So those elements of the infrastructure become pretty important, and things around care management, analytics, and so forth. But as you mentioned, John, elements and the foundations around clinical integration are really key.
Okay, so this one, they didn't create a company. They just had an agreement between the two organizations. And there's an amazing amount of work to build in the buy-in and the trust between the two systems. I have a cardiology department, A and B, and to get them to work together, it's important in that process that they're involved from the ground up in developing what the infrastructure is going to look like, what the metrics are going to look like, and the overall process. And they all have to understand that they're not ceding control of their organization or their practice. Rather, they're collaborating on what that's all about. So here, there's no company formed. It's just an agreement, and a committee is set up to do the same kind activities that you would do within the organization. I don't have a strong preference for one or the other, but I can tell you that a lot of people tend towards creating an entity because that entity sort of gives some validity to the effort in their minds or their optics. And that then relates to the doctors and the hospitals around the service lines that you are integrating. Let me comment on that a little bit. We've seen one service line integrated across 2 hospitals, and we've seen a situation where a university hospital decided that they had too many patients in their 4 walls that they really didn't need, and it was choking them. In other words, those people could get care other places. They joint ventured with a community hospital in the neighborhood, and the idea was a lot of these patients would be triaged or sent to the community hospital for those care services. Could very well be done there. And on the other hand, some of the services that were being performed at the community hospital that should have been at the quaternary hospital should be shifted there. And then they set up an entity to oversee the whole process. So, and they did it across, the plan was to do it across 13 different service lines. So there's a one service line or there's whole hog. So that's a big project. But the idea there is whether it's 1 or it's 13 or somewhere in between, what you're doing is creating a situation that works for both systems. I'm going to shift to the next slide.
John, quick question before we get off there. Okay. The governance, in my mind, I think is really important, right? I mean, as you start to think about how these 2 entities need to work together, in your experience, what have you seen that has been successful as these joint ventures have set up governance models? What have been some of the aspects that you've seen that has really allowed them to kind of get past some of the challenges?
Well, you've sort of built it into everything you said, because what you're doing in that process is building trust. You're building trust. You're building a common vision. You're building an idea that, we're not different. We could do this. We're going to share ideas. I'm not sitting here as Hospital A or Hospital B. I'm now Cardiology Group AB. And that you don't merge them all together in terms of employment or things like that. But you get people to really work together. They begin to trust each other. You break down the silos in the process of building the organization, and then ultimately the organization can function. So it's sort of like the only way to do this right has a side benefit, and the side benefit is that you get past that. You start to build some trust, and you're talking.
I think the trust and having a common vision. I couldn't agree with you more. I think absolutely, as organizations start to think about that.
And Dan has said this throughout now, and I'm just repeating it, this is always a win-win. In a simple way, a tertiary hospital upgrades level of services provided at a community hospital on a specialty by specialty basis. Okay, you don't have invasive cardiology at your hospital, but we could build a pre-stent program for you or something along those lines. We could help you how to organize and recruit more patients to your institution that are perhaps driving past yours and mine to go somewhere else by having a program that's specialized and targeted, and there's a lot of information, and you talk about prevention and do all those kinds of things. So those are all good things. And you're shifting levels of care from a community hospital to a tertiary hospital at the same time. People aren't getting things that shouldn't be done somewhere else. If you think that's not a reality, look at what Walmart has done with their patient care. I mean, they've totally shifted where patients are going and entered into very advantageous arrangements where me as a patient, if I choose to go somewhere that Walmart doesn't want me to go, it's going to cost me a lot of money. So there is this is already happening from a consumer perspective. What we're talking now is about how do we start talking to each other from a win-win perspective.
What we've seen within Walmart is they've actually contracted regionally with different providers. So, there was they've done they did some work with Northwell, they did some work with Cleveland Clinic. I know that With Ochsner, you know, they direct contracted as well too. So they are really trying to find the high performing clinical service lines within their regions, within their, you know, within their communities, if you will, and direct contract with them. And, you know, again, I think those provider organizations that have been able to differentiate themselves, they put themselves on a different plane, both with payers and in particular with the employers.
You well said. The differentiation is critical. In the 70s, it was don't ask me about my quality or what I do. It's my business, not yours. Throughout the 80s and 90s, oh, we're all great. You know, now you have to be able to show you're great. You have to have a story to tell, and you need the data.
Yeah, couldn't agree with you more. So with that, Lisa, I'm going to turn this back over to you. And I don't know if there's any questions, but John and I are available for the next few minutes to answer anything that might come through.
Great. Well, thanks, John and Dan, for all that great insight. So our first question is, in building a clinical service line strategy, do you start with conversations with your payer and a contract first, or do you build the clinical service line?
Yeah, that's a good question. You know, I think in my mind, it actually happens in tandem because you're not necessarily starting from scratch. If you have the basics of the specialties there, you know, you need to start to think about what the strategy is to bring the specialists together, both internally within the organization and then within the community. But, and I'll let John jump in here. I do think it's critical that you have to have an entity, right? I mean, you have to have something there that you're going to contract around, especially if you're starting to think about some type of a performance-based contract. You do need to have that as well. John, you know, any thoughts on that?
Yeah, you're right. You have to have a program. You have to have something under the hood, as we say. You have to have a program. How do I sort out what the program is? Well, you already know what your high cost service lines are. And you know which ones are being utilized heavily in the community. It's taking those and working around them so that now I have a program and a story to tell to a payer or particularly employers about why my institution is better and what we've done. One of the challenges we had in early clinical integration was the health plans would push back. We'd go to the employers and say, this is what this network is prepared to do for you in terms of cost, in terms of managing costs and all those other things, even as far as to go to payers and try to get a claims run so somebody can take a look at it and say, look, you're getting killed in this area or that area. Let us focus on that for you. So you're absolutely right.
Yeah.
You have to have a program.
Yeah, and I think, you know, as you mentioned, I mean, you do have to have something under the hood, and at least initially it's not that hard to build. I mean, there is a starting point. You know, it sort of gets me thinking back. We had worked with the clinical service line, you know, about a year and a half ago, and we looked at the hospital outcomes for cardiology services. And then they were, of course, interested in bringing in the independent providers as well as then they had a few employed cardiologists as well. And we looked at the specialty MIPS reporting for cardiology and being able to combine those with the hospital outcomes. Granted, it wasn't, you know, tremendously comprehensive, but it was a great starting point. And you're able to actually see how well the physicians had performed. And frankly, for this institution, they actually performed pretty well. That was a great place to begin to launch a conversation.
All right, and our next question is, what is needed to start building out the pricing models for clinical service line bundles?
A lot of times the pricing, you know, when you talk about the pricing, you're really thinking about what the medical spend is. You do have to have an idea of where patients are going. Ideally, you need to have the claims data. You could sort of back into it from some of the billing data that exists across, you know, the hospital and the providers, but you know, what you don't know is where patients are going outside of that network. So, you know, having the claims data becomes important. You start to think about then or answer the questions around where patients are going within the different care settings, what the medical spend is, utilization components around that care setting. All of that taken together was what allows for that episode pricing. And, you know, it does become, you know, a strong foundational component. Now, of course, if you're moving into a bundled pricing with Medicare or CMS, you know, there's an opportunity there to be able to get that claims data, which, is a great way to at least be able to get your feet wet without kind of jumping all the way into the pool. But that's typically where it starts.
And do you see commercial payers engaging in bundled pricing with clinical services or just Medicare?
Well, Medicare right now has been the most predominant. In some markets, we are seeing commercials get involved in this. As John and I said, we're seeing some of the large employers getting involved in this. Here in Chicago, United Airlines has worked with one of the large academic groups and clinical service lines to do pricing around orthopedic care. So, we are seeing that. I think as clinical service lines start to be more predominant as a way of delivering, specialty care, we're going to see more and more of the payers start to embrace that. And John, I don't know if you have any comments around that, but at least as of right now, it's pretty much what we've been seeing.
I completely agree, but here's the way to think about it. Payers weren't creating value-based contracts at all. Providers had to start selling them. So if you're selling a bundled product, you've now advanced, you've sped up the curve for people buying it because there's a product to buy. One of the problems that people like Dan and I run into all the time is that people don't believe your program is real. They don't, well, show it to me. They want to put their finger in there and take a look at it. So if you build it, they will come. I mean, you have something to sell. Payers themselves aren't going to design these programs, or if they do, their orientation to what metrics to use has everything to do with cost and very little to do with quality.
And then earlier you mentioned collective negotiation. How does that work, and how can you negotiate price?
Well, that's a good question. The idea is this. It goes back to the last question, actually, because if you build a product that's fully integrated in the way that Dan has particularly described it, you are clinically integrated. And, we could, somebody who understands clinical integration and the law could tell you that. If you ever want to have a conversation, I shouldn't say this, they're going to hate me, but we have had informal conversations all the time with the Federal Trade Commission on our models just to get they won't give you I don't want an opinion. That takes 2 years and $100,000. And, but you can sit down with them for the cost of airfare to Washington, D.C. and talk to them about your model. So you could build something and show it to them if you're concerned. But I wouldn't be concerned at this point in time because you are clinically integrated and even though you're competitors, you're coming together in a way that modifies physician and hospital practice patterns, reduces costs and improves quality. You're a joint venture, you're a clinically integrated program, and you have the ability to collectively negotiate. What Dan was getting at earlier is, what are you negotiating for? Is it a bundled payment? Is it a shared savings? Is it a value-based thing? That's something you've got to work out with yourselves and then the payers.
Yeah, I absolutely agree. And, it's around really, kind of gets back to, what that vision is and what's the path that's going to get you there, and again, I keep going back to it. I think a lot of times as organizations are thinking about this, continuing to think about how they differentiate themselves in the market, how they need to be different. And especially if you're combining academics with community providers, if you're in a metropolitan area where there's 2 or 3 different academics, you've got to find a way to differentiate yourself. And boy, the clinical service line model really does provide a lot of support for that.
And lock in referrals. I mean, you're able to, you're taking it for granted in many cases that you're going to keep getting referrals from certain communities. I wouldn't take that for granted too much longer.
And one last question, what is the role of physicians generally in this process?
Well, I think, physicians have a really strong role in this. You have to have a strong physician specialty leader, for instance, if you're building a cancer service line, an oncologist who really understands the broad-based activities of cancer services. You also need to have that physician develop their skills that will allow for a lot of the culture transformation that has to occur. As John said, especially if you're going to be forming these joint ventures, you know, you're going to be working through a lot of dynamics with different entities. The physician leader has to be astute enough to really begin to manage through some of those challenges. But the key in my mind is really about changing or transforming the way the care is delivered. And having a visionary physician leader that can help lead that change with their colleagues, boy, that in and of itself is worth their weight in gold. So I really do think that evolving leadership skills, that evolving physician leader is a key to success in any of these clinical service line models.
Great. Well, thank you for sharing all these great insights. This is contact information for Dan and for John if you'd like to get in touch with them directly. And you can check out Lumina Health Partners online at luminahp.com. You can follow us on Twitter at LuminaHP, follow our Lumina company page at Lumina Health Partners, and also check out our YouTube channel, Lumina Health Partners, where we post all of our webinars and you can watch those for replay. So thank you again for joining us today, and we hope to see you on a future webinar. Have a good afternoon.